So it's a great pleasure, let's say, to present at the end of this year the clinical webinar of the Mobilise Consortium on the hip fracture cohort. We're doing this work as part of a relatively large EU consortium, which is called Mobilise-D, and we're focusing on different clinical cohorts, and we're looking at the future role of digital mobility markers that we will present. Mobilise-D is a consortium that has a lot of academic partners. The overall budget is about 50 million euros. We're now in the 4th year of the project. So after, let's say, having a lot, of course, to do during the pandemic, we have successfully recruited many patients that you will hear about. Basically, of course, initially I want to say that we're presenting this on behalf of the consortium, and we're not presenting the view of the European Commission. So for today, we are presenting the current state of the hip fracture group within the Mobilise Consortium. We have different sites where we're recruiting patients. In the first part of our webinar, we will present the state of the research, what we've been doing so far, and also including some work on scoping reviews and some, let's say, work on digital biomarkers that we have actually collected before the consortium. And then in the second part, we'll move towards the technical validation study, and we will also present the study protocol and give some insight on how the study has been running so far. So my initial part will be that I will give you some background data for those who are not totally familiar with this cohort on hip fracture, on the incidence, on what we know about the mortality, what we know about function, and what gains have been made over the last decade or so in this field. And then from our side, why we need the future or the current use of digital mobility assessments or outcomes in this cohort and what this will bring us. Of course, we're building this on a lot of work that, for instance, has been done within the British, let's say, region. For instance, the work from Chris Todd, the work from Carl-Göran Törngren from Sweden. And of course, there's a lot of ground that we currently build on. So globally, we expect that by the end of this decade, we will have around 2 million hip fracture cases annually. And let's say, based on the demographics in most countries, these numbers are slowly but surely increasing. Currently, we have very robust data, for instance, from the London School of Economics and Harvard Medical School that show us that there is still quite a bit of discrepancy of 12 months mortality, indicating that we have different service models. And for instance, France, currently this paper that I've cited is from a European perspective in terms of the #1 performer. And we have other countries that somewhat struggle with 12 months mortality. We have seen that in orthogeriatric services, these are numbers from Germany, where we have examined the role of orthogeriatrics, that if you run a co-management program, that you can decrease the mortality by probably up to 20 or 25% during the first 4 weeks. So you can bring down the mortality from maybe 10 to 8 or 7%. So that's been shown in a number of countries. And now increasingly, for instance, in Germany, this is a mandated approach that is now being introduced for the whole country. We know from controlled trial, these are data from the Trondheim hip study that is also part of our consortium, that if we do this, we do not only have effects on mortality, but we also have effects on mobility, meaning improvement, significant improvement. We have improvement in activities of daily living. We have improvement of health-related quality of life. And we can also make a difference in terms of care home admission. Even more so, for instance, the Trondheim hip study that was published in the Lancet showed that this is also very cost-effective. And so following this trial and many other trials, countries or institutions like in Scandinavia and other parts of the world have introduced this or are introducing this step by step, let's say, as their national approach. Aside From mortality, of course, what the Cochrane review, for instance, is calling a poor outcome is the question of care home admission. These are, let's say, from more than 50,000 cases that we have observed in Germany, showing that, for instance, hip fracture, if you live in the community before the hip fracture, increased the risk of care home admission to about 10% at 6 months. And of course, this is no outcome that any patient or family would want. At the end of last year, the updated review of the Cochrane group was presented on hip fracture rehabilitation, what can be done. And basically, this second Cochrane review stated that there are effects of rehabilitation if we introduce this very early on, according, let's say, to the state of our knowledge. But as you can see, the effects to some extent are somewhat modest. So we need to find approaches that not only decrease mortality, but also improve function. The conclusions in a very brief manner are that there is moderate certainty evidence for inpatient rehabilitation, but we need to think how we can improve the surgical procedures, the training approaches, the multidisciplinary approach. And this, of course, should be coordinated by a medical specialist. However, the Cochrane's review also stated that, unfortunately, currently no further robust conclusions can be drawn on other outcomes, such as, for instance, 6 months mobility or 12 months mobility. So there's further work to be done. One of the papers which I think very nicely described this is a paper that was led by Suzanne Dyer and the group, also, let's say, including J Magazine, who will be our discussant today. And the overall finding is that along with stroke and many other chronic conditions, we need better operative, better post-operative and post-acute treatments. And we also need to measure mobility disability in a much more, let's say, granular way. And based on this, our group, but also other groups, think that it's time to include digital mobility outcomes to have real-world measurements in this cohort. So the current state is that, of course, we see a lot of different ways across the world how we can look at this and how we can improve treatment strategies. For instance, some countries are still investing heavily in inpatient rehabilitation. Other countries are investing in home-based rehabilitation. Other countries such as the Netherlands, or also to some extent the US, are heavily investing into skilled nursing facilities as part of a long-term care approach. And one of the things is, of course, that we want to look for comparative effectiveness research across these countries to identify what are the best, let's say, procedures in order to improve the outcome of this very frequent condition. So why do we need digital measures? For instance, we need to very properly and robustly identify new surgical implants or procedures. There's a number of pharmacological interventions in the pipeline that we expect to start maybe next year or the year after, for instance, to improve sarcopenia as a treatment strategy. And of course, we want to understand in terms, for instance, of dose and response, how we can improve exercise interventions and maybe also complex rehabilitation studies. We want to understand how we can stratify people that might be identified successfully for early supported discharge, which increasingly is now in most countries happening earlier and earlier, for instance, on day 3 or 4 or 5. And of course, we also want to identify the people that might be eligible, let's say, for a prolonged period of rehabilitation to improve their outcome. Some years ago, David Oliver published this paper in the BMJ, and he said that to some extent, to study hip fracture and let's say in the way he has described this is one way as a role model for many conditions in operative medicine, but also for old people. Because we can almost identify any case. We have a situation where we almost have no missed cases. So let's say, at least from an older person perspective, this is an ideal condition that we could use, maybe also to learn for other conditions that are somewhat similar and somewhat related. For the purpose of today, we will present findings from a scoping review that will be done by Beatrix Verrijken from Trondheim. Then we will present sensor data of several hundred patients from pre-existing data sets, which I think for the first time will be presented to a global audience. Then we will have the first session with our discussant and possibly also from Q&A from you. Then we will have two patient voices describing their journey with a hip fracture. And after that, we will have some insight into the work on the technical validation study that has been finished within Mobilise-D. And then finally, we will present our current work of the hip fracture study within Mobilise-D. So now I will hand over to Beatrix Verrijken, who is a professor of movement sciences at NTNU in Trondheim. And if there are questions, please put them in the Q&A. Thank you.
Thank you, Clemens. I'm Beatrix Verrijken. I'm based at NTNU, and Kristen Tarlson, she was here as well, but she's now at the Oslo University Hospital. So in Mobilise-D, I'm involved in validation studies, and I'm leading the work on dissemination and exploitation. So why should we care about mobility in patients with hip fracture? Well, first and foremost, because patients themselves care a lot about mobility, and it's vital for their independence and quality of life. And we're about to publish a comprehensive review, which was led by Laura Delgado Ortiz, in which we looked at the walking experience from the perspective of the patients. And one of the things that we learned is that the sense of self of these patients is strongly connected to how they experience their walking. And this again is influenced by physical, emotional, social components, the context, etc. We also learned that despite the obvious importance of the patient's voice, their perspectives are rarely included in studies. So out of more than 2,500 records that we identified for this review, only 4% reported on patient perspectives themselves. And we only found 10 studies on hip fracture patients. So we obviously need much more work in this area. And this is also where Mobilise-D is making important contributions. And you'll hear more about that later in this webinar. The second reason why we should care is that mobility changes dramatically after a hip fracture. So in many older people, mobility is fine. It might slowly decline over time, or maybe we see a steeper decline, but then it plunges to zero mobility with a hip fracture. As Clemens mentioned, some hip fracture sufferers, they don't survive at all, with about 30% dying within a year. Of the survivors, only about half come back to approximately their pre-fracture mobility function. And the remaining 40 to 60% do not regain the earlier function. And 10 to 60%, depending on the study, they do not return to their previous residence and instead are admitted to a nursing home, for example. So how mobility changes after hip fracture is highly informative about the recovery. But how can we study mobility? Well, if we want to assess mobility in general, there are many ways to do that. First of all, we can just ask the patients. So then we can get a variety of what we call patient-reported outcomes. And these are highly valuable, but they're also subjective and they're not complete. We can observe. A few things that we can readily observe is how slow or fast a patient is walking. We can see whether they're limping very badly, for example. But also this is pretty subjective and it's also very coarse. It doesn't inform us about more specific changes in mobility. To get to these more specific changes, we can test the patients. And this gives us objective and more detailed information about their mobility. But this is typically done in a lab or a clinic, which is expensive because patients have to come to the clinic and we need highly specialized expertise to do these tests. And it only gives us a snapshot of what the patient is doing that particular minute almost, rather than what they do in daily life. There's another disadvantage of clinical testing or laboratory testing, is that when we assess mobility in the clinic, we often ask patients to walk in a straight line over an even surface. And that is not at all representative for mobility in the real world, because in the real world there are obstacles, we are influenced by the weather, we take turns, we go up and down. So this is a far more complex form of mobility, but it's also the kind of mobility that matters the most to the patients. It's not so much what they can do that one time in the laboratory, it's what they do in their daily lives, going to the grocery store, playing with their grandchildren, for example. So we need to get to this picture of what mobility is like in the real world. What if we move to assessment of gait in particular? So here we can actually calculate many, many diverse gait characteristics, literally hundreds. And these are commonly organized in larger domains of gait, such as pace, for example. Here you would have gait characteristics such as the speed of walking, stride length. We can look at the rhythm of the gait. Then you would have characteristics such as cadence, timing. We can also look at the base of support, so how far apart patients put their feet when they're walking. We can look at the variability or the variation in all of these gait characteristics, which says something about how consistently the patients move. We can look at asymmetry, so left-right difference in the gait of patients. And then finally, we can also look at the volume of gait. And this is one of the most typical things that studies have looked at. So then you look at the number of steps during a day, for example, or how much time you spend walking during a day. If you want to know any more about the walking definitions or the terminology that we developed in Mobilise-D, you can have a look at this paper by Felix Kluge that you can find on the Mobilise-D website. So which of all these possible parameters have been used in research in general and hip fracture research? And what did we learn about mobility changes after a hip fracture? So to answer these questions, we recently undertook a scoping review on the clinical usefulness of the digital mobility outcomes that have been reported so far in the literature. And this was work that was led by Ashley Polonis. And here you see the same 6 domains that I just showed in the previous slides, along with several specific gait characteristics. Do not worry about the long list of variables that I mentioned here. What I want to draw your attention to is that of the almost 900 papers that we included in the review across all the cohorts that are part of Mobilise-D, there's relatively few that focused on hip fracture. And the far majority of these studies evaluated gait only in the clinic or the lab. Gait speed was by far the most used digital mobility outcome, but it was typically measured by a stopwatch, even though there are more accurate measures these days. And it was mostly evaluated in very, very short walks, so either less than a minute or less than 20 meters, which again may not be representative of what patients want to be able to do and have to be able to do in their daily life. All the other possible parameters were either not included or in very few studies only. And what I found most surprising, or actually most shocking, is that gait asymmetry, which is perhaps the most salient characteristic of gait after hip fracture, was included in one study only. So we decided to look deeper into this and do an updated review, also looking at the papers that came out the last 2 years, and then focus on clinical trials that evaluated the effects of various treatments and how much focus have these really had on gait or mobility in general. So this is work that is being led by Kristen Tarlson, and we have identified 33 papers that report on gait parameters in a clinical hip fracture trial. And the treatments evaluated in these clinical trials varied widely. So they consist of various surgical methods, exercise interventions, other interventions, or combined interventions. But also here, most of these studies report short walks, mostly gait speed, and mostly, again, only using a stopwatch. So far, we've only found 7 papers that included additional gait parameters. And only 3 papers that actually looked at how people move about in daily life settings using wearable sensors. So this, despite of everything that we have learned of these important papers, there's huge gaps in our knowledge about mobility recovery after a hip fracture. So how is Mobilise addressing these gaps in our knowledge? Let me put back this graph that I showed you earlier. How do we move from these graphical depictions to understanding what really underlies these different trajectories? And most of all, what are the actual trajectories of gait recovery in the real world, not based on lab data? How can we influence the trajectories and maybe move patients from a lower trajectory to a better trajectory? Another question we need to answer is how can we move the study of mobility out from the lab and into patients' daily lives? And then finally, how can we how do the mobility changes map onto clinical assessments and patient-reported outcomes? So these 3 questions is actually what the remainder of the webinar will be focused on. And so it's my pleasure to now introduce Jochen Klenk from the Robert Bosch Hospital in Stuttgart, Germany, who will present trajectories of mobility outcomes after a hip fracture that are based on actual real-world data. So Jochen, the floor is all yours.
Thanks, Beatrix. Good afternoon. Yeah, I'm Jochen Klenk. In Mobilise, I'm part of the team working on the data analysis, especially on the sensor-based activity measurement. In my talk now, I will show results from an ongoing analysis of already finished studies, not data from Mobilise. We estimated trajectories of mobility outcomes after hip fracture. And the results I will show are preliminary and not published yet in a scientific journal. This is in a way pre-work of the Mobilise-D data analysis that we will also perform with the data we get from Mobilise. I also want to mention the great teamwork. So this is also here to show the co-authors that are also part of the work I will present. So now the next slide. So I hope you see the next slide now. Okay, so you already know this figure because Beatrix previously showed it. She very nicely explained that, yeah, we are very much interested in mobility trajectories of patients after hip fracture surgery. Yeah, we have a good idea from a conceptual point of view how these trajectories may look like. But mobility trajectories based on large data sets with enough measurement points in time are currently not available. Mobilise will provide such data, but so far we must use other sources and other approaches to get this information. In the analysis I will present, we use data from different cohorts of hip fracture patients with limited numbers of DMO measurement points after hip fracture surgery. And we try to combine these measurements to get a combined estimate of the trajectories. In this cohort, some time points overlap and some not. By combining these cohorts, we can fill the gaps and get a time series that is sufficient to estimate trajectories for different DMOs. And further, we also want to identify if there are different groups within these trajectories to get a better understanding what is inside and if people behave maybe different. So coming to more details to the methods, we used data from proximal femoral fracture patients after surgery, 65 years and older. We combined 4 studies and pooled them together. I will show you in a second how the data looks like. And the strength of the data is that all cohorts use the same sensor to measure physical activity. It was an ActivePal-3 device, which is able to distinguish between walking, standing, sitting, or lying. And the DMOs I will show today are daily walking duration, the volume measure. I will also show daily maximum number of continuous steps within a single walking bout. This means how many steps did a person continuously walk without a break. And finally, we also have a number of sit to stand to walk transfers, which are transfers that lead from sitting to a walking episode. The study populations are from Trondheim in Norway and Stuttgart in Germany, 2 from Trondheim, 2 cohorts and 2 cohorts from Stuttgart. The mean age was comparable, about 83 years. And also the distribution, the variability between the cohorts shown by the standard deviation here are very comparable in the cohorts. The proportion of females was about 75% in all cohorts, as we also would expect it in this age group. We also have information about the mean gait speed at month 4 and for Profile 2 at month 6 after the surgery. And it shows that the cohorts still have functional limitations at this time point. Okay, in total, the pooled cohort contained 785 older people. So now to give you an impression of the data, the next 4 slides will show each single measurement group by cohort. First, you see the Profile 1 cohort. Where's my cursor? Sorry. Okay, the Profile 1 cohort, the x-axis shows the number of weeks since surgery, and you can easily see the different assessment points of the study. On the y-axis, we have daily walking duration measured in minutes. For this cohort and also for the next one I will show, the Profile 2 cohort, we don't have currently the exact surgery date. We will get this in a few weeks, but currently we assume the same surgery date or the same distances. That's why all measurement points are on one line for the free assessments. This is also the case for Profile 2. In Profile 2, or with both cohorts, you see that the time points, the assessment time points do not overlap, but they complement one another. And that's the idea of the analysis. Here you see the data from the Trondheim hip fracture trial. It shares time point with Profile 1 at month 4. And here we have the exact surgery date. So you see there's a spread in the time points here. And this is also the case for the EFA hip study, which you see here. Additionally, at month 6 and month 12, we have overlapping data from more than one cohort. The rehabilitation period usually ends after 4 months. This is expressed here by a gray line. This can also vary a little bit between the cohorts, but just to give you an impression where it roughly ends. So with the pooled data, we are now able to estimate the trajectories of different DMOs for the whole population. And the first DMO is the daily walking duration, the volume measure. So you can see the estimated trajectory here as a black line. We see an increase of walking until about 6 months, here with the red line, marked at week 28. And the strongest increase is during the rehabilitation phase. We also see that about 15 minutes is the maximum walking per day that is reached by the cohorts on average. It's relatively low if you compare it with community dwelling people of the same age group without a hip fracture. For example, data from the Active cohort in Ulm measured with the same sensor. Here we have about 90 minutes of walking per day in the same age group. On the long run, it seems that the walking duration in our patient decreased at the end, but at the end on the tail, we have also high uncertainty. So this is something we have to see in a bigger data set if this is really the case. And when you look at the single measurements, you see also that there's a huge spread in the data. So there's on individual basis, there is a high variability, and we will see later that that we also can estimate different trajectories, different groups within this cohorts. This is what I will show you the figure later. The next DMO we analyzed was maximum number of steps within one walking bout. The pattern looks similar, but the maximum of the trajectory is later compared to the previous one. It's here roughly about 40 weeks, 10 months, where we have the maximum. On the y-axis, you now see number of maximum steps, and the maximum that is reached is about 250 continuous steps. I try to recalculate it in meters. If you assume a step length of 0.3 meters, it's roughly 75 meters that is continuously walked from this person in the maximum. Okay, and the last DMO is number of sit to stand transfers, sit to stand to walk transfers correctly. Sorry, wrong. So, okay. Here you see that the maximum is reached much earlier in the rehabilitation phase. It seems that the number is not changing much afterwards. The number of transfers is roughly around 40. And it might reflect more the need of transfers to manage your daily activity than that it reflects a functional status of the persons. But that, I think, is something to discuss. But I think this is a quite interesting pattern that you reach a plateau very early for this measure. I already mentioned that we try to differentiate these trajectories further. The mathematical method we used is a latent class analysis. We have to assume a number of classes that we wanted to estimate. So by clinical considerations, we assumed 3 models to keep it simple and to also consider the number of cases we have, so that the trajectories are not too small. And we also tried to estimate the characteristics of the patients that are within each of the trajectories to get an idea who is included in each of the trajectories. So today I will only show the trajectory for walking duration. And we also truncated the trajectories after 6 months, because this is the phase that is mostly affected by the surgery. And afterwards, the uncertainty based on this method is high. So we decided to truncate it at 6 months. And as expected, you see that there's a lot of difference in the data, and that you can estimate 3 trajectories that are really different when you look at the endpoint at 6 months. Most of them are in the lowest group, with about 75% of the cohort here in blue. And the mean age of the highest group is 84 years about. And the group with the green trajectory has a mean age of 82 at 6 months. The daily walking durations is about 3 times higher compared to the blue line. And the green group includes about 20% of the participants. And finally, we also have a high-performing group in black with 5% of the participants at a mean age of 79 years. The gender distribution varies a bit between the trajectories, but this also might reflect just the age distribution, the different age distribution of the trajectories. Okay, so coming to the discussion and the limitations we have to consider. With the cohorts we used our intervention studies, and we included all people, so also the intervention group and as well as the control group. This might have affected the results or affected generalizability of the data. Furthermore, we did not have people from care homes in these cohorts. This is an important group in general, with possibly different trajectories. We hope to get this information in Mobilise-D to also estimate these trajectories. And yeah, currently we also assume the same trajectories for all the 4 cohorts we included in the analysis. It seems that there is no cohort effect. We can test this, but we have to look deeper in the data to be sure about that. And finally, due to the method, we have to pre-specify the number of classes we wanted to get. This was a decision of clinical consideration, but also of the available number of patients. In Mobilise-D, we will solve this problem of sample size, I think, but also some of the other limitations. So we are very much looking forward to collect all the data and see if we can confirm these trajectories and findings, and to have a deeper look into the trajectories of these patients. Okay. Coming to the conclusions, summing up, we saw the trajectories of DMO progress differently for volume variables such as walking duration and capacity measures such as maximum steps, or also C2 stand transfers, and that the measures reach a plateau at different time points, and that for the whole core, the activity levels are relatively low compared to their peers without a fracture. And when we spread the cohort in 3 classes, 75% of the participants had a even lower activity level of about 25 minutes walking per day. So this was a quite big group with such low levels. And a bit surprising for me was that the early plateau of the C2 stand to walk transfers. And as I already said, this might reflect the daily demands more than the functional capacity of the patients. But this is something we also can discuss later. So if you are interested in the cohorts, here are the references, and thanks for your attention. Now I hand over to Clemens.
Thank you, Jochen, for this very interesting insight. I think this is very, let's say, novel data that hasn't presented anywhere else. And of course, we're now looking forward for the discussion. And we have asked Professor Magaziner from the Johns Hopkins, let's say, Baltimore Department of Epidemiology. He's been the director there for quite some time. But for us, even more important is that Professor Magaziner has been leading the Boston hip fracture trials for a very long time, bringing some very relevant insight into this patient group. So, Jay, I will hand over to you for your comments, let's say, of what you see, but also, let's say, your perspective on this group, what can be done and what should be done in the future. Please, Jay.
Thank you, Clemens. You know, it's hard to know where to start. I have so many thoughts that I'm trying to figure out the best way to present this. So I'll just get started and see if somebody sees me going off track, just bring me back. First of all, I think it's an extremely impressive body of work that you've done so far, and presumably there's more to come in the future. I think the amount of background work you've done, and I think that Beatrix did to review the prior work and the limited prior work with these mobility, these digital mobility measures is striking. And yet there's a lot of work in other areas. And I think one of the things that will be important, and you alluded to this, Beatrix, in looking at how some of these digital mobility metrics relate to other measures. You mentioned PROs in particular, patient-reported outcomes in particular, but there are probably other metrics that one could look at to try and determine what some of these mobility measures, how they relate to other issues that might be important. And I think what I want to do is show you, I have a slide that might be useful. I've got several that I considered bringing up. Let me share my screen for a moment. And most of the work that I'm going to talk about comes from what I refer to as the Baltimore HIP studies. And what I wanted to show you is that, and our program is designed to identify, develop, and evaluate strategies to optimize recovery in multiple areas. And I think what you've done is we know what goes on with survival. We have some ideas about what happens in many different dimensions of recovery: physical and function, instrumental function, affective function, social function, pain, cognition, strength. Now you've moved into physical capacity, and there are many other measures of outcome. As you point out, Beatrix, there's very little work that's been done looking at any of the objective digital measures that take place out of the clinical laboratory. There are patient-reported outcomes outside the clinical laboratory, but there are no direct objective measures. And what I think is going to be important is we need to describe these, as we've done. And I think Joachim has done a beautiful job of looking at trajectories. And I have some other data, some other models. We've only here started to look at different components, different groups of trajectories, as you did in your latter analyses that you showed. That's not my own area, but some of our biostatistics group is getting more interested in using different latent class modeling that I'm sure you understand better than I do. But I thought it was some beautiful work, the way you showed some of these patterns of recovery. So there's a lot to be learned from these very descriptive factors. But a next step for you, and you started doing this when you looked at the male and female differences and the age differences in some of these patterns, but you can really probably look much further at what is responsible for who does well and who doesn't do well, okay? And some of those may be modifiable. The ones that you showed are not modifiable directly, but what they proxy for, what they stand for, may be modifiable. So older age, probably more comorbid conditions, probably. And the question next will be, what are those conditions? Which ones are driving those patterns? And how can we start to manage those from a sense of intervening to improve the trajectory of recovery, in whether it's a mobility measure or any of the important functional measures that relate to recovery. So I think that the other comment I wanted to make had to do with, and I thought Beatrix had a very nice diagram that talked about not just the progression of measures. And I was taking some notes. You looked at, there were issues of the PROs, the gait speed and symmetry. You can test objectively what happens in a clinical setting, but then you have the real world parameter. And you do get a very objective account of what's happening in the real world. And I liked your diagram that showed, some bumps in the road and the streets and the sidewalks are not level, and there are obstacles that come about, and there are ledges, curbs that you step off of when you cross the street. So there are many things that one has to accommodate to and consider in how you interpret different dimensions of mobility. So it struck me that you know, there are environmental factors to think about, and the community environment that they're in, as well as their own physical characteristics and physiologic factors that may enter into what drives mobility. So what are the mechanisms underlying that mobility? And I don't know, my 10 minutes are up, so maybe I'll come back and say a few things more later. But I think that the basis for what you're doing is critically important. And as you learn more about the different patterns and the different mixtures of people, then it's a matter of how do you unbundle that so that you can actually make a difference to draw the recovery up higher. And this is where I wanted to go back to something that I thought was really interesting that related to one of the diagrams that you both showed. You know, function is going to be declining as people get older, okay? No matter what dimension of function you're looking at. And then with a hip fracture, there's a very sudden drop in function. You showed that in your diagrams, and I think that's one of the reasons that hip fracture is such an interesting model to use for looking at how people can recover from any number of conditions where mobility is depleted rapidly. And then people recover, okay? And you showed this pattern, and in fact, Joachim, you began to show that after about 6 months, people start declining again. Some people actually start declining. And there may be actually just like what they would have done had they not had a hip fracture if they're in relatively good health otherwise. But ultimately, what we want to do, and this is where the intervention comes in, what can we do really to get them boosted? And I think that's what we're all trying to figure out. So first we measure and observe, and then we need to look at how we can look for improvement. So I'll stop here with this beginning, and then try to figure out what I'm going to say in the last 10 minutes as I hear more.
Thank you, Jay. First of all, of course, I must excuse, and of course, you're right, the Baltimore hip study and not the
That's
Boston.
Okay. And I want to correct you one more. I'm not at Johns Hopkins. I'm at the University of Maryland.
Oh, even worse.
We're 3 miles apart. But from what I understand, you're still in Berlin. Is that right, Clemens?
No. Thanks for that. Okay.
Yes.
We'll take it on sometime, maybe next year at FFN in Oslo or somewhere, then we continue.
Yes.
Thanks so far, Jay. Okay, to move on, there was one further question from Peter Augert, who's a professor of biomechanics, and he's asking about, let's say, prediction of trajectories for these cohorts. And Peter, at this moment, I must say that this is something to be worked on, and definitely will be a major part also of the Mobilise-D data set. But at this moment of time, we cannot come up, let's say, with a robust model for what you're asking in terms how can we predict that what might be the people that might, let's say, need a prolonged period of rehabilitation. In most countries, the rehabilitation period is something between maybe 3 to 4 weeks. And then hopefully in some countries, we have some home rehabilitation. But that's exactly what we need to understand to personalize these interventions and gain the most that we can. So for the next part, we will see 2 short videos, in a sense, giving, let's say, some insight into the journey that some of these people are having. The first video will be from a patient that actually was recorded for the German public broadcast system very early on the 2nd day of his hospital stay. So Martin, please show us the first video.
Ich war zu Hause und dann hat der Getränkefritze geklingelt und ich war allein zu Hause. Und dann bin ich raus mit dem Rollator und dann hat mich eben gehauen.
Ich wollte gestern Nachmittag meine Eltern besuchen und bin dann ja so gegen 3 Uhr gekommen und habe schon gesehen, dass die Wohnungstür aufstand, was eigentlich untypisch ist. Als ich die Treppe hochgelaufen bin, habe ich gesehen, dass mein Vater auf dem Boden lag, direkt vor der Türe und flach da lag und ich natürlich total erschrocken.
Ich lag auf dem Boden, ich konnte nicht selber aufstehen und es hat dann 2 Stunden dauert, bis jemand kam.
Er war natürlich schon öfters gestürzt in der letzten Zeit, weil er eben schlecht laufen konnte und eben nur am Rollator. Aber es hat eigentlich ja dann schnell sich herausgestellt, dass es diesmal schlimmer ist und nicht einfach ein Umfallen war, sondern eben ein stärkerer Sturz, der eben dann ja jetzt zu dieser Verletzung geführt hat.
Diagnose: Oberschenkel-Halsbruch.
The second video was taken from a patient that actually is a participant of the Mobilise-D hip fracture study. So we followed this person for quite some time, and then this again was taken from the German broadcast system.
So schnell die Treppe hinunterzugehen, das war für Hermann Dinjes lange Zeit nicht möglich. Vor einem Jahr stürzte er genau hier, in seiner Garage. Damals stand da noch sein Auto.
Ich bin ums Auto rum und wollte was holen hinten. Und da bin ich auf irgendwas, ein Stein, oder war es ein Stückchen Holz, oder was da rumgelegen war, ein Grust, drauf gerutscht. Wenn das eine weiche Wiese gewesen wäre, hätte es vielleicht nichts gemacht. Aber da hat er Beton. Und dann noch direkt da drauf, wenn ich auf dahinter gefallen wäre, hätte es vielleicht abgefedert. Ne? Aber da bin ich direkt dann da drauf gefallen.
Hermann Dinjes stürzte genau auf seine linke Hüfte. Er musste operiert werden, bekam ein künstliches Hüftgelenk. Anschließend war er 5 Wochen in der Reha. Seitdem macht er die dort gelernten Übungen zu Hause.
Ich fühle mich fast so sicher wie vorher, mit der Einschränkung, ich passe jetzt besser auf wie vorher.
Ob sein Gang wieder ganz stabil ist, das wird der 87-Jährige gleich erfahren. Denn heute ist sein Kontrolltermin im Stuttgarter Robert-Bosch-Krankenhaus bei Professor Clemens Becker.
Was wir heute noch mal vorhaben, ist, dass wir uns die 3 wichtigen Themen noch mal angucken, wie ihre Ausdauer ist, wie weit sie mit der Kraft und wie weit sie mit der Balance gekommen sind.
Professor Becker ist Altersforscher und hat als einziger Deutscher an einer Studie der Weltgesundheitsorganisation WHO zum Thema Stürze und wie man sie verhindern kann mitgearbeitet.
Das Hauptproblem ist, dass tatsächlich eben dann doch etwa 10% sich bei einem Sturz wirklich auch teilweise schwer verletzen. Und man braucht doch eine ganze Zeit, um wieder so aus der Talsohle dann rauszukommen und um da wieder hinzukommen, wo man vorher war. Das ist schon ein hartes Stück Arbeit.
Ein Sensor am Rücken zeichnet alle Bewegungsdaten von Hermann Dinjes auf. Professor Becker überprüft mit seinem Expertenblick, wie stabil und sicher sein Patient geht.
Man sieht so, dass er an der Kehrtwende ungefähr 4 Schritte gebraucht hat. Am Anfang brauchen die Leute oft 6 oder 8 Schritte. Er geht sehr flüssig. Diese Koordination, das Gehen ist jetzt schon deutlich besser geworden in den letzten Monaten.
2, 1, los. Im nächsten Check geht es um die Ausdauer von Hermann Dinjes. 6 Minuten soll er zügig gehen.
Ich gucke mir die Füße an, ob die Leute gleichmäßig gehen oder sehr ungleichmäßig gehen. Und gerade in der zweiten Hälfte sieht man dann, ob die Leute müde werden, ob sich da irgendwelche Veränderungen einstellen. Man sieht, dass er für seine Gruppe sehr flüssig und sehr schnell und flott eben schon auch unterwegs ist.
Ich bin sehr, sehr zufrieden, bin glücklich. Ich merke eigentlich gar nichts mehr. Na, nur wenn ich ganz besonders mal was Schweres habe, dann muss ich aufpassen. Aber ansonsten merke ich gar nichts mehr.
Hermann Dinjes ist zufrieden. Jetzt geht es auch für ihn darum, sich weiter fit zu halten. Mit vielen kleinen Übungen für zu Hause. Denn nochmal stürzen, das will er auf gar keinen Fall.
But we wanted to give you some insight that this second person, he's now 87 years old, worked very hard in his rehabilitation period and regained most of the things that he could do prior to the hip fracture. So I think we have these examples that sometimes can be quite different, let's say, from case to case. So, and we need to listen to the patient voices. In my professional life as a clinician, I probably have, let's say, talked to maybe 8,000 or 9,000 hip fracture patients. And it's always that we learn from those. So it's not only the quantitative information, but also when we listen to the patient voices that, let's say, should help us of improving these treatment strategies, but also have a shared goal setting and decision-making process. So the next speaker today will be Martin. He's a PhD student from Trondheim, and he will report on the process of the technical validation study that we have done so far and how we have developed the algorithms that are then also applied in the clinical validation study and about the progress we've made there. Martin, please.
Thanks, Clemens. In this presentation, I will talk about expanding our understanding of hip fracture recovery and what is lacking in our understanding. Monitoring physical activity after hip fracture has been used by researchers for several years already, using body-worn sensors, as you see on this picture. Physical activity and inactivity have been measured both in the acute phase at the hospital, during rehabilitation, and after treatment. But which measures have been derived from this monitoring? Not really all that many. We have the upright time, which is the time per day spent in standing and walking, and we have the number and length of daily upright events. We also have the number of daily steps and cadence, as well as time walking and time spent sitting or lying each day. However, changes in real-world mobility after hip fracture have not been studied so much. And the table you see here summarizes which digital mobility outcomes have been used. And from these studies, we learned the following. There are few changes in real-world physical activity in the first 6 months. Patients are mostly inactive with no changes after 6 and 12 months. Motivational interviewing over 8 weeks increased physical activity, and acute treatment at a geriatric ward gives a beneficial long-term impact on participants' daily physical activity. And the strength of these studies is that they have all monitored physical activity in the real world. But the weaknesses are that the used mobility outcomes are quite general and not that gait specific. So they inform about the amount of physical activity and inactivity, but very little about more specific gait characteristics. So therefore, the next step is putting focus on recovery of mobility and gait. And what is needed for that? This requires the ability to measure gait reliably in people's own daily life. So how do we develop the necessary tools for this? We took this body-worn sensor technology and did a technical validation study comparing in-lab and real-world data. And I will now show you the patient journey in the Mobilise technical validation study. And our hip fracture participants, they were recruited and tested by our colleagues in Stuttgart and Kiel. And first, the participants had to sign a consent form and go through the screening process regarding inclusion and exclusion criteria. And participants meeting these criteria were included and provided background information. And we collected descriptive information, comorbidities, number of falls, walking aid usage, and current medications, as well as assessing activities of daily living and physical function. After answering the questionnaires, the participants were ready for the in-lab assessment. They got a microbit sensor fixed to their lower waist, as you see on this picture, and they performed various standardized mobility tasks with different complexity. To validate the sensor in the lab, we measured what participants were doing using reference systems, which were a 3D motion capture system and a system with pressure insoles. Then we had to take this out of the lab and into the real world for a 7-day mobility assessment using the same microbit sensor and a GPS with GPS information collected by a phone. And if the participants used a walking aid, we fixed a beacon to it. The next part was interviews and questionnaires, where we wanted to know the participants' evaluation of the microbit sensor. And in the final part, we visited the participants at home to do a 2.5-hour free living assessment. And there the participants wore the microbit sensor and the pressure insoles together with the GPS and the beacon. And they were asked to complete different unsupervised activities from a checklist, such as rising from a chair and walking to another room, walking stairs, walking to the kitchen and making a drink, and walking outside, etc. So then we left them at home with this system recording for 2.5 hours. So to validate the in-lab digital mobility outcomes from the microbit sensor, we compared its performance with the reference systems. We also validated the pressure insoles against the gold standard 3D motion capture system. Then these pressure insoles could be used as a silver standard reference system to validate the microbit sensor in the 2.5-hour free living assessment. So then finally, we could validate new real-world digital mobility outcomes. And here you see the summary of the overall validated digital mobility outcomes results from the technical validation study across all our cohorts. And this work was led by Claudia Massa and her team, and you can get more information about it by watching our first 5 webinars on our YouTube channel. The digital mobility outcomes you see here are based on walking bouts. And walking bouts are sequences of walking with at least 6 steps. So the primary digital mobility outcome, walking speed, was valid, but only for walking bouts lasting at least 10 seconds. And most secondary digital mobility outcomes were valid as well, except for stride length, when all walking bout lengths were included. Swing and stance phase durations were not accurate enough to be valid. So the technical validation study has resulted in additional reliable digital mobility outcomes that we can use to evaluate real-world gait. And compared to only those that have been used previously, which is number of steps and cadence. And now we can get a much more detailed picture of gait changes after hip fracture, where it matters to the patient, which is in the real world. So using these digital mobility outcomes, we can expand our understanding of hip fracture recovery, but the validity of the digital mobility outcomes was based on 4 disease cohorts, and not only the hip fracture participants. So which digital mobility outcomes are accurate in the hip fracture cohort? We know that the hip fracture cohort was the oldest and frailest cohort, and we know that slower gait with shorter steps and shuffling decreases accuracy. And also about 2/3 used walking aids, which also impacts the results. So how can we dig deeper into this? We are now investigating how the accuracy of digital mobility outcomes may change with times in surgery. If outcomes are not accurate shortly after surgery, will they improve and become accurate as participants recover from their hip fracture and regaining mobility? And what about the effects of walking bout lengths? As I mentioned, walking bouts longer than 10 seconds have better accuracy for all cohorts, but does this apply to the hip fracture cohort as well? By looking at accuracy stratified by walking bout length on the same timeline, we can see which walking bout lengths are more appropriate. And this would be a very useful to know for our clinical validation study analysis. So now we have the necessary wearable technology and validated algorithms that allow us to study real-world mobility and gait in more detail. And does this also lead to better clinical understanding? Our next speaker, Carl Philip Jansen, he will present how we address this question in Mobilise-D.
So yes, I'm very happy to be a speaker here this afternoon, and thanks to all my previous presenters, of course. And now for the final presentation from our part, before we have the last part of the discussion, I'll talk about the clinical and the patient-reported outcomes and the hip fracture cohort, and why are they important and what is important. So the mobility transitions in hip fracture can vary. Of course, we have a pre-fracture status or a pre-fracture mobility of the patients that we're looking at, and in Mobilise, we're looking at patients who are able to walk before the fracture. And of course, then they have the fracture. It happens mostly because of a fall. And the question is, how is the trajectory of their mobility afterwards? And another question we're asking is, where do the people end up living? Is it that they have to go into institutionalized housing situations because they're not capable of living an independent life anymore? And of course, this has a lot of detrimental effects for those persons. Or are they able to go back to their own housing and live in their previous situation? So the question of housing is also something that is relevant to some degree. I will talk about this later. But first, we have several outcomes in our study which we use to answer the main questions. And you've heard a lot about digital mobility outcomes, DMOs, in the previous talks. And we are using two types of sensors for that. But we also have clinical outcome assessments, of course, and also patient-reported outcome measures. And we need both in addition to the DMOs, because the DMOs tell us what a patient does in real life, but we need to understand the function and the capacity of the patient. We need to understand based on which grounds this mobility trajectories evolve. And we also need to understand how a patient feels, or how the patients feel about not only their mobility, but in general, because there are several factors that could influence their mobility. I think Professor Magaziner has put it quite exactly, that there are many things that can affect the mobility of the persons in real life. So just for you to understand how often we measure those persons, there's the study design. So we have 5 measurement time points. We start with, of course, the baseline measurement, and then every 6 months, people are coming back, hopefully until the end of study, which is after 2 years. And in this time frame, we will capture this data. And not all of this data is captured every 6 months, but most of them are captured every 12 months. And of course, we need to understand the trajectory over 1 year and 2 years. And there are several, for example, in hip fracture, we're looking at the feel component every 6 months. Now, there are two primary endpoints in our study. One is a global primary endpoint for the whole Mobilise consortium or the Mobilise study. We have 4 cohorts here. Of course, we're discussing the hip fracture cohort today, but there's also the 3 other cohorts that are equally important, which are the COPD, multiple sclerosis, and Parkinson's disease cohorts. And to have a comparison across all of those 4 cohorts, we're using the late life function disability instrument. I'll explain it to you in a second. And we have a primary endpoint only for our cohort, which is the care home admission at 6 months. So we have one very hard objective endpoint. Does the person end up in a care home or not? And we want to look at their mobility to better understand, are there certain trajectories of mobility that can predict this happening? And we have a subjective endpoint, which is the late life function disability index. So what is that? It has 2 dimensions, the function and the disability dimension, as the name already tells you. And the function component asks how much difficulty do you have in doing a particular activity. And this is very precise questionnaire. So there's very clear activities. For example, opening a glass or a bag of chips. So people have to explain how hard it is for them to do that. And the disability component also asks how often persons do something, for example, meeting with other persons or going outdoors or taking a longer walk. How often do people do that? And if they do it, to what extent do they feel limited in doing that? So this is people have to rate themselves. And so that's a patient-reported outcome of mobility. And we're, of course, taking this into account when looking at the digital mobility assessment and or outcomes, and we are linking those 2 components. This assessment has been validated. There's literature on meaningful change estimates and also a clear explanation rationale for the development of its components. So if you're interested in that, you of course can look this up. And in terms of clinical outcome assessments, we have a larger battery of functional tests, the short physical performance battery that is probably familiar to most of the persons who are here today, the timed up and go, the 6-minute walk test, so how far can you walk in 6-minute time, and the hand grip strength test. And most importantly, actually, we're instrumenting those assessments, which means that we're using a sensor, also from McRoberts, to get further data on the execution of those tests. So it's not only how long does it take, but also how do people walk, how many steps do they take, how is the symmetry of those steps, and other information. So we want to have a really clear and in-depth view of the capacity of the persons. Now, as I've said before, there's many things that could affect mobility in real life, and we want to understand those factors, at least parts of those, because we cannot capture everything. But the question how patients feel, for example, in terms of fall risk or loneliness and isolation or pain, their own pain and their fatigue, helps us to better understand actually how their mobility actually evolves in their real life. So how is it possible that this happens? And maybe we can better understand with this data that a person who has a good capacity does not move that much because they're afraid of falling, for example, have a huge concern about this. And as a second layer, we also look at the extent of the mobility. So how far do people go? How often do they leave their neighborhood or the town they're living in? So overall, this gives us a comprehensive understanding of the patient's mobility that hopefully will help us to answer the main study questions in a clear manner. Now, there are some PFF cohort-specific assessments. I don't want to bother you with this too long, but I think it's important to understand that we have a larger battery of assessments that help us to understand pre-fracture function, so that they have to tell us about how their function was before they had the fall, and also their cognitive status, because often, of course, cognition is important to understand if you want to evaluate mobility of the persons. Now, a short sneak peek, and this is almost my last slide, just for you to see where we are actually right now. So we have included 405 patients so far, and we're looking to get 600. You can see here the retention rate. So the blue line is the baseline assessments. 405 patients have done that, and about 230 or 40 persons have done the 6-month follow-up. So this is still running and running. 1 year follow-up has been completed by about 100 persons, and there's already the first one starting, the 18-month follow-up. Now, the patient overview, so we have 59 persons that are still active in our study of those 405, and you can see that 38 persons have withdrawn and 8 have deceased in this time. So the dropout number is actually lower than we expected. And also very interesting to see is the age range that we have, so 46 years until 95 years. So there are 26 persons that are younger than 65 years who have fallen, had a low energy fracture as we define it. And the mean age is 79 years, which is a little bit lower than the data that Jochen Klenk has presented. And you can also see the distribution of men and women in our study. But this is nothing that we wouldn't expect based on previous studies. The outlook is that the last patient will be included in March next year, and the last patient out will be 1 year later. So for those, we won't have 5 measurement time points, but only 3. The study protocol is published. You can see it on the right-hand side. It's open access. You can look it up if you want. And we're planning for publication of baseline and follow-up data in the next 2 years. And as Jochen has already said, we will use the Mobilise-D algorithm to look at this time series analysis and maybe have a even better or more sophisticated way of capturing this. And there are 3 sites. And of course, I want to use my last slide to thank the whole team. There's so many persons involved. You can see many names here, and they've all done a great job in getting this study up and running. And I'm very happy to be part of this. So with this, I would like to finish my talk and open the discussion again and give the podium to Jay. Thank you very much.
So thank you, Carly. Jay, your second round.
Yes, thank you. I just make a few comments in the few minutes we have remaining. It's a tremendous body of work, and I appreciated what Carl Philippe presented in terms of the extent of the program and the amount of information being collected. Those are the same cohorts that you're getting all the digital mobility outcomes in, is that right? I want to make sure we're talking all about the same cohort. Yeah. So this is, yeah, I mean, it's amazing what you've been able to do. I thought the videos were extremely revealing. And the second gentleman that you showed, Clemens, you're a magician. The way you've been able to help him to do so well and regain his confidence and everything that goes into his mobility. I mean, and I think you can see how tragic for a person this can be to lie on the floor for 2 hours. And I think we all can talk about cases that have been on the floor for much longer than 2 hours, waiting and dehydration and cognitive problems. And so many things happen during that period, in addition to all the physiologic changes that are taking place. So I thought, Martin, your rendition of mobility was really interesting, and it speaks to digging deeper into the different dimensions of mobility. On the surface, you see what walking as being important, and I would guess that if you asked 100 patients what's most important, I think they would say my mobility, being able to get from, whether it's from their chair to the toilet, or from, you know, their house to their daughter's house, or being able to bend down and play with their grandchildren, or whatever it is. It's all good mobility. And I think what's important is looking at the dimensions of mobility to understand how we can address them and intervene with them to change what dimensions can be modified to improve mobility. And then I think the Carl Philippe's look on, and it's everyone's look at, how do these measures converge and how do they map to what patients think are important? And I think the regulators, at least the FDA in the United States, is very, very concerned with the patient's perspective on what's important to them. If we could get something that is important to the patient, maps closely to what the patient says is important, but is an objective indicator of what their mobilization is like, it would be a very efficient way of being able to chart somebody's what's important. Sort of like blood pressure is something, it stands in for so many possible problems, but we measure, put a cuff on their arm, we say, you have low blood pressure, let's treat it. Well, you could give them a drug to treat it, but you also could do other things to help reduce the problems that they're having. And I think we need to move hip fracture into that world. And I think it was Stephanie Studinsky had said that, you know, if there were a fifth vital sign, she would have it be walking ability. So, I mean, I think you can tell so much, and I think you're really honing it down much further. I don't know if I have time, but I'm going to take the next 4 minutes to show you something.
That's fine. Yeah.
It's okay. What you might find interesting, we've looked at patterns of recovery, a lot like what I guess it was in the earlier presentations where we had different trajectories, and we've looked at, for example, walking. Different aspects of mobility seem to have a slightly different point, different rate of recovery, and a different point at which they plateau. They reach that peak level of improvement. And this is without any additional special interventions. We mapped this for many different functions, and this is just percentage dependent in walking. And I think we could model that. And I think that's very much like what you've done already. And then we looked at where different functions plateau. This paper came back out in 2000, so it's not been repeated. And I would like to ask the group to consider, as you accumulate more data, to consider whether you would get something like this again as you start looking at trajectories of change in different dimensions of function. So affective function and cognition seem to be, we need those. They're more basic to improvement than balance and gait. And then the higher level functions seem to play out in terms of how they're actually functioning in the world with their lower extremities and instrumental tasks. This is a very simplistic approach, but in a way, and I showed you this before, the underlying pathology of osteoporosis we can treat. Basically, what I'm getting at is there are many different interventions that can be brought to the table. And I think what we saw was that patients after maybe 6 months, some of them start declining again. And I would think that the benefits of rehabilitation may have come to an end by that point. And I'm going to end this and say the benefits of the rehabilitation may come to an end and maybe they need a sort of a booster, another. I mean, if they are doing the same exercises they were doing at 4 weeks, when it gets to be 6 months, they may not be doing enough. So what can we do to extend the rehabilitation period to improve mobility further? But in regard to the Mobilise-D program, I think that having this information on hip fracture and being able to contrast it with other conditions will actually prove very valuable in terms of whether we can ever get a generically appealing measure that can be used in geriatric populations more globally in the future, in addition to what we learn specific about each condition. So I think, you know, I don't know that I can say much more right now, but I am just fascinated by what you've been able to do. I knew a little bit about it, Clemens, but not so much. So this is the Mobilise-D program. Fantastic work.
The sound stopped with you, Jay. I don't know. Is there a technical problem, Mara?
No.
Oh, Jay, we didn't hear your last words. Sorry.
I said, you want to hear it again? Okay,
yes,
I'll
sure.
say it
It sounds so nice.
Fantastic program of research. I'm really, there's great value in what is to come, especially in the work you're doing with hip fracture, which is what I'm most passionate about, but also what it will teach us about geriatric care across multiple conditions. So it's really critical generically, but also in terms of the specific conditions.
Okay, thank you, Jay, so much. I will finish up saying that, let's say next year we'll have the baseline data. We'll have, let's say, 6 months data. One of the occasions where hopefully, Jay, we will meet is at the Fragility and Fracture Network meeting in October in Oslo. And that's, in terms of timelines, I think an excellent place then to meet. Jay has also been chairing the FFN for 2 years. So it's a pleasure to meet people from very different backgrounds and very different disciplines. Well then, thanks for your interest in Mobilise-D, and we'll keep you posted. And for those who could not attend from your colleagues, invite them. The webinar will be uploaded probably 1 week from now, more or less. And then everyone who's interested, let's say, will get their chance. And by then we'll cheat a little bit. So let's say when I introduce you, Jay, I will do it in the right manner if we upload this to YouTube.
It's okay. It's not unusual.
Thank you so much.
But I just want to say one thing about the Fragility Fracture Network. I think that there is one of the special interest groups that deals specifically with research on recovery from hip fracture. And it's, you know, it's an emerging group. Clemens was involved earlier in that, and it's really moved in a lot of directions. And it would be wonderful to have more people involved in that. And just look at the Fragility Fracture Network website. And the Fragility Fracture Network is pleased to have been one of the co-sponsors of this in terms of getting the word out about this wonderful program. Thank you.
Thank you to you. Thanks to the speakers. Thanks to all of you listening and watching. And hopefully you all will have a very peaceful time in this crazy world. So probably meet you then next year. Thanks.